Hello, everyone. Welcome to the Estimands Academy for Trial Teams. My name is Judy Danzures Cabrera, and I have the honor to present today the fourth webinar of the series. We titled it Proposing Estimands from Different Perspectives, Patient, Clinician, Regulator, Health Technology Assessor, and Statistician. The webinar is brought to you by the Estimand Implementation Working Group that is sponsored by FPI, the European Federation of Pharmaceutical Industries and Associations, and the European Federation of Statisticians in the Pharmaceutical Industry. The EIWG brings together statisticians and clinicians in the journey of the Estimand framework. We are a group of more than 30 people, and we represent pharmaceutical companies, CROs, and regulators. Before we start, we would like to thank FPI and FPI for sponsoring and promoting the webinar. We also want to thank PSI for hosting the webinar, to Emily for helping us in the background with the webinar. The webinar will be recorded in the PSI website and the YouTube FPI channel. Also, we want to thank the EIWG members for reviewing the slides and giving us very good comments. We all want to make a disclaimer that the webinar gives an illustration of different perspectives and possible solution thinking, but is not intended to be taken as the perfect solution. Our opinions are not necessarily the views of all our respective companies, representatives of the roles we play, regulators of HTAs. Next slide. Yeah, well, I will be moderating the session. And I have the pleasure to introduce Nikhil Kamath, who is my colleague at Roche. Nikhil is a Group Medical Director and Global Development Leader within Global Product Development, Immunology, Infectious Disease, and Ophthalmology. Nikhil brings his perspective as a clinician and will be representing the role of the patient. We also have David Wright. David is the Head of Statistical Innovation at AstraZeneca, previously worked for the MHRA, and led the revision of the CHMP guideline on missing data in confirmatory clinical trials. He brings his perspective from his experience as a regulator. Antonia Morga is a Global Health Economics and Outcome Research Director. She co-leads the EIWG team on health technology assessments and real-world data studies, and is part of the FPI HTA working group. Antonia will be representing the role of a health technology assessor. Last but not least, we have Sue McKendrick, who is a Statistical Science Director at PPD, where she leads the cross-functional Estimand Working Group. She brings her role as a statistician. Now, before handing over to Sue, I want to mention that we have a Q&A section in which you can type questions at any time during the webinar. During the Q&A section, we will start asking the question to the panelists. With that, I hand over to Sue.
Thanks, Judith. So the agenda for today is that myself and David are going to introduce objectives and background, and then Nikhil is going to talk about a case study of a fictitious compound called Tic-Toc-PSI in heart failure, but we hope we've really brought a lot of realistic features to this case study so that you'll be able to relate to that. We're going to talk about strategies for handling intercurrent events into Estimands and explain some of that terminology. So if you've not come across that before, don't panic too much. And part of the point of today as well is to try and think about different perspectives that different members of the team might bring, and how that interplays when we're thinking through what it is we want to find out in our study and formulate those estimands. So we'll move on to talking through a few different options for how you might formulate an estimand, and then the challenges and recommendations at the end. leave quite a good amount of time, 20 minutes or more, for the Q&A session that Judith will be chairing. And all you need to do, if you have a question as we go along that you would like to be asked at the end, you just type that into the Q&A panel, and Judith will be able to read that out. And there's also an option for you to put a thumbs up and effectively vote for your favourite questions, and that will push those up the order of which are asked first. So we do hope that you will be engaging with this presentation, and there are a few quiz questions along the way, and we hope you enjoy it. So the objectives for today are to apply the Estimand framework to a challenging, realistic setting and discuss perspectives of the different stakeholders when determining estimands. And hopefully we'll be able to understand the relative merits of different strategies for intercurrent events and share some tips for implementation. So the word Estimand, it's all about what it is we want to find in our study, what we want to find out, and ultimately be able to estimate the treatment effect, effectively, that we're interested in. But it has 5 different interrelated attributes. The population that we're wanting to study, the target population. What are the treatment conditions we're wanting to compare? What is it we're going to be measuring? What's that endpoint we're measuring on the individual? How are we going to make our comparison? What is going to be our population level summary? And we're going to introduce this concept of intercurrent events, but what are the strategies for dealing with those? We'll talk about that a little more in a minute. But it's very much related to the objectives of the study, and really trying to think through those and how the clinical setting that we have interplays with that. And therefore it does need a cross-functional discussion between everybody, and we'll want to ensure that we have agreement with regulators, health technology agencies, and so on. So this has all come from, of course, the ICH E9R1 addendum. It's very much advocating those multidisciplinary discussions. I'm going to pass over to David now to introduce the framework.
Thank you, Sue. So Sue's mentioned this document, ICH E9R1. So I'd just like to start by explaining, although that is an addendum to a statistical guideline, it's that this Estimand framework is far more reaching than that, and is really concerning the whole team, as you saw pictorially on the last slide. And so that was maybe one of the things that it would have been better if it was a more general guidance rather than just an addendum 29. But that's just one point to bear in mind. In terms of the framework, as you see here, it's just a logical sequence of steps with a top-down process. One of the reasons it was created was because it was seen that quite a few people running trials might start at the bottom with saying, well, we'll just estimate the treatment effect in this way. But they haven't defined what they were interested in first. And so the first part of the process is to have clear trial objectives, and then you move on from those to define the Estimand. And once you've done that precisely, that enables you to tailor the study design accordingly to best answer the trial, answer the objectives that you have. And once you do that, following the study design, you can then define estimators and then come up with an estimate of benefit. Just to say that this webinar will not focus so much on the statistical methods. It'll be talking about the Estimand. So you can relax if you're a non-statistician. You don't need to worry about lots of squiggly algebra. It's going to be focusing on the Estimand. So on this slide, you see that another benefit of clearly defining things is when you get to the other end after the trial is read out, and you see something like this, which is a product label for Entresto. So we're not picking on Entresto. This is just to illustrate a point that back then, before Estimands were really on the table, this is maybe a way that you might see things summarized. And we've sort of gone back into that and trying to pick out what the Estimand would have looked at, what would have looked like. And so you see here that we were sort of, we could do that, but there are some important things, like in this particular example, there was a run-in period. So it's sort of implicit that they were looking at patients who were able to tolerate the drug. But this sort of wasn't made overly clear in the documentation. So this would be something that could have been improved upon if the Estimand framework had existed back then. I think I'm handing over to Nicole now.
Thank you, David. And so now we can launch into our case study of Tic-Toc-PSI in heart failure. And this slide summarizes the target product profile for this fictitious product. So that's important to remember. I don't think we should get too hung up on the science here. We're using this purely for the purposes of illustrating a hypothetical scenario that we can now walk through. And so for the purposes of this particular product in the context of heart failure, it's really important to recognize that what we're focusing here is on symptoms and the potential for symptomatic benefit, and not necessarily having an impact on mortality or other factors. It's purely the symptoms that Tic-Toc-PSI that we're interested in. And then on this TPP, you can see the study design and endpoints. And also it illustrates the fact that we're thinking of this as an add-on treatment to standard of care for heart failure. And you'll be familiar with the commonly used standard of care treatments such as ACE inhibitors, diuretics, beta blockers, etc. So the idea is that this fictitious product would be used on top of that. And for the purposes of this exercise, we'll just call it an XYZ inducer. And it's aiming to improve breathlessness, swelling and fatigue by regulating the heart muscle function. The prior phase 2 study was completed, and it appeared to show that there was benefits on quality of life as measured through the so-called Kansas City cardiomyopathy questionnaire. There was some benefits in a 6-minute walk test, so a test assessing the functional capability of participants, and a suggestion of an improvement in cardiovascular hospitalizations. And for those unfamiliar with the patient-reported outcome tool, the KCCQ, this is something that has items looking at physical function, symptoms, self-efficacy, and social function. Next slide. So then, after completion of the phase 2 study, as typically we see in drug development, we now are ready for a phase 3 study and program to develop Tic-Toc-PSI. And here you see the objective listed on the screen to demonstrate superiority of Tic-Toc-PSI over placebo, importantly when added to the standard of care to improve quality of life in heart failure patients. And then here we see, through this fictitious example, the primary Estimand and its 5 attributes. And so you'll remember these 5 attributes as were illustrated on a previous slide earlier on in this presentation. And the first 3, we can think back to the target product profile and how these can be filled in. So the population, we're talking about moderate to severe heart failure. The treatment conditions are 2 groups, so Tic-Toc-PSI twice a day on top of standard of care, and placebo on top of standard of care. And because we're looking at the impact on symptoms, the primary endpoint is the same patient-reported outcome tool that was used in phase 2, the Kansas City cardiomyopathy questionnaire at week 52. And this is a scoring tool that is scored from 0 to 100, with a higher score being better. And then finally, at the right-hand side of the slide, there are the two remaining parameters. So the population summary, and we'll come to this later on, but this will be looking at things like change in medians or relative risk, for example. And then also, importantly, our strategies for intercurrent events. So if we click again, and important to note that the design details should follow Estimand agreement. And so intercurrent event strategies may impact what data are relevant to collect after intercurrent events. So now here, what do we mean by intercurrent events? So we see a very helpful definition here provided by the ICH guidelines. So events occurring after treatment initiation that affect either the interpretation or the existence of the measurements associated with the clinical question of interest. So in a real life situation, intercurrent events will always happen, and these may have an impact on the outcome. And so therefore, consequently, the interpretation is important. In the interpretation, it's important that we make clear what these are, and again, very importantly, how we will handle them. Exactly what intercurrent events depends on the context, clinical setting, and outcome measure. So for example, treatment discontinuation, meaning discontinuation of the investigational therapy or the reference project. So from now onwards in this presentation, you'll see this depicted as this blue symbol that you see on this slide. So initially, it's helpful to think about the different reasons for treatment discontinuation. And we may end up dealing with all reasons in the same way, or there may be different approaches for dealing with them, depending on the reasons. A second example of an intercurrent event is changes to background therapy likely to impact the outcome. And you see this here depicted through this yellowy brown symbol in the middle of the slide. So again, it may be helpful to think of different categories, such as those given for worsening symptoms or those given for unrelated medical need. And then finally on this slide, another type of intercurrent event is any terminal event such as death that stops the existence of the outcome. So this is something making it impossible to have a quality of life outcome rather than a missing data issue. And so you see this through this black symbol on the right-hand side of the screen. Next slide, please. So now coming on to a quiz question. So hopefully you can all have a go at answering this. So which of the following is not an intercurrent event? Treatment discontinuation due to tolerability issues, study withdrawal due to burden of the study, taking rescue medication, or none of the above. So take a moment and record what you think is the correct answer. Just waiting for the responses to come in.
We're just over 70%, so I'll let another few come through.
So last few seconds.
I'll go with 80%. There we go, and I'll just share those for you there.
Okay, so we see two clear front runners in terms of the responses there. So there's 36% for study withdrawal due to burden of the study, so that was B, and then none of the other is getting 52%, and then A and C are getting 6% each. So the correct answer here is B, study issues that resulted so study withdrawal due to burden of the study. So just a bit of background here. So study discontinuation or other issues leading to missing data is not an intercurrent event per se, but instead these represent data limitations to the data that needs to be addressed through statistical analysis. So for example, in our Tic-Toc-PSI case study, the patient withdrew from the study, will still have a quality of life, but we can't measure it due to discontinuation. And so according to the ICH E9 R1 guideline, the definition of an ICE should be limited to events that affect the interpretation, and events that affect the existence of the assessments without affecting the interpretation should be considered as missing data. So this is an important differentiator here in how we should think about these type of situations. And subjects who withdraw from the study may have had an intercurrent event prior to the withdrawal, so that's important to keep in mind. And because the estimand is to be defined in advance of the trial design, neither study withdrawal nor other reasons for missing data are themselves intercurrent events. So for example, so the example showing this is study withdrawal. So as distinct from withdrawal from treatment, according to the guidance, while withdrawal from treatment should be considered an intercurrent event, withdrawal from study as a whole should be handled as missing data. Next slide, please. Okay, so now we hand over to Antonia and Sue, who start to talk us through strategies for handling intercurrent events into Estimands.
Thank you very much, Nikhil. We have seen how the strategies for addressing intercurrent events are one of the critical attributes of an estimand. Let us now look closely at which strategies we can consider and how these strategies reflect different research questions of interest. To begin with, we can look at a treatment policy strategy. Now, under this approach, the treatment effect for a given variable or outcome of interest, in our case, for example, KCCQ score, are estimated irrespective of the occurrence of a given intercurrent event. In this case, irrespective of the occurrence of treatment discontinuation due to toxicity. It is important to note that a treatment policy strategy calls for gathering of data and observation even after the intercurrent event has occurred. Importantly also, under a treatment policy strategy, the target of inference, in other words, the cause to which we can attribute the outcome we have estimated, will be reflecting not just the treatments to which patients have been randomized to, but importantly, the intercurrent events that they would have also experienced. Under a composite variable strategy, we incorporate the intercurrent event into the definition of the variable of the endpoint itself. For example, we might be interested in estimating the number of patients who would have achieved a clinically meaningful response to our treatment. We might also be interested in incorporating into the definition of response the fact that some patients would have experienced this meaningful change without also experiencing treatment discontinuation due to toxicity. This will give us the new variable, the new composite variable that we could qualify as responders without treatment discontinuation, and we would qualify as non-responders all other patients. If we continue our journey to understand the possible strategies, we encounter the hypothetical strategy. Now, under this strategy, we are interested in estimating the treatment effects in the hypothetical scenario that a given intercurrent event would not have taken place. In this instance, we would be using the relevant data observation for which we have been gathering from randomization up to the point where there is where the intercurrent event takes place, in this instance, up to the change in background therapy. From that point onward, we would be relying on statistical methods, imputation methods, in order to inform our estimate. And Sue will soon elaborate on the importance to make sure that the methods we rely on are both clinically and statistically sound. Under a while-on treatment strategy, we are interested in estimating the treatment effects for a given variable of interest up to the point of the occurrence of a given intercurrent event. This strategy lends itself quite well when we are in presence of an endpoint of a variable which we will measure at repeated point in time. And finally, we encounter the so-called principal stratum strategy. Now, under a principal stratum strategy, thank you, Sue. Under a principal stratum strategy, the clinical question of interest relates to the so-called target population. The target population is defined as the principal stratum in which an intercurrent event might or might not occur. It is very important to appreciate that we need to emphasize the fact that we are trying to ascertain this strata a priori, pre-occurrence of the intercurrent event. As a consequence, this approach also relies, just like the hypothetical strategy, relies on statistical methods that allow us to identify the relevant strata of patients. And again, it will be important to make sure that this approach and the methods it relies on are both clinically and statistically justifiable. Over to Sue now to understand a bit more around the methods that can help us estimate the variables of interest, reflecting these possible strategies.
Okay, thank you. And I guess the other thing about principal stratum is it might need a particular type of design, the run-in period, for example, that David mentioned. So one of the things I thought was perhaps worth a bit of explanation is what we've found useful when we're thinking about different clinical settings is to think about what are the intercurrent events and what do the patient journeys look like. So here we have different patient journeys with some patients who have discontinued the treatment. So it's a fairly simple patient journey in this case. Obviously, it might be more complex than that, but just wanted to focus a little bit on what is the difference between a while on treatment and a hypothetical strategy. Because one of the things about these two approaches is they might well end up using, if you like, selecting the same data as being relevant. But the key thing is the endpoints will be different. So for while on treatment, on the left, it could be that we're very much interested in the slope or rate of change or an average prior to the intercurrent event occurring. And it could also be that the treatment durations are expected to differ. So we might also perhaps be thinking in terms of a rate of occurrence adjusted for the time period, things like that. So literally the endpoint is very much geared towards what's happening prior to that intercurrent event. Whereas on the right-hand side, this picture is supposed to depict the idea of a hypothetical estimand, where what we're interested in doing is predicting or imputing, at a particular time point still to come, like so at week 52, for example, as those still on treatment. Okay, and actually a lot of statistical models kind of do this. Repeated measures models and multiple imputation models, for example, are very good at estimating things in a sort of hypothetical way. But is that a sensible way to pose your question? And it might make a lot of sense if, for example, people have discontinued treatment due to perhaps a logistical issue. It might make a lot of sense to take this approach. However, if the reason for discontinuing treatment is a tolerability issue, then is it sensible to even contemplate, what would have happened as though they carried on taking something that they clearly weren't able to take? So it does require some careful thought on the appropriateness of using this strategy. So a quiz question for you. So again, hopefully you can see a poll appearing and you can give your view. The question is, a hypothetical strategy for handling an intercurrent event means we are interested in the effect in all patients prescribed Tic-Toc-PSI. Is it irrespective of the intercurrent event, as though they do not experience the intercurrent event, over the period prior to the intercurrent event when they were being treated, or considering the occurrence of intercurrent event as treatment failure? Lastly, in the subset of patients who would not experience this intercurrent event. So you might have in mind something like treatment discontinuation due to logistical issues, say, as your intercurrent event. So if you would take a guess if you're not too sure, but basically answer the poll that's come up, and we will show the responses very shortly. Thank you. And just one other thing to mention as well is a lot of people are putting questions into the chat, and we would really appreciate you putting your questions that you want to ask for the Q&A at the end into the Q&A panel instead.
Okay, we've got 75% there, Sue, so I will share those results.
Lovely. Thank you very much. So we've got a clear winner here of option B, as though they do not experience the intercurrent event. And yes, that is the correct answer. So thank you all. Each of these actually did correspond to one of the 5 strategies that Antonio introduced earlier. So you can see there the first one, irrespective of treatment policy, over the period prior to the intercurrent event is while on treatment, considering the occurrence of intercurrent event as treatment failure, it's composite, and in that subset of patients who would not experience this intercurrent event is principal stratum. Okay, so we're going to move on now and think about different perspectives for handling intercurrent events. And over to Nikhil first of all.
Thanks, Sue. So now for this next section, let's put ourselves in the shoes of some of these key stakeholders and think about intercurrent events from their perspectives. So what questions do you think they would have about Tic-Toc-PSI? So we're going to go through each of these stakeholders one by one now. So next slide, please. So first of all, Pat Hart, the patient. So I will be putting on my patient hat and giving a perspective of the things that I would be thinking about. So I get tired and short of breath, can walk about 100 meters, then need a rest. Sometimes I notice my ankles are swollen. I've been in hospital a few times with difficulty breathing and fluid on my lungs. I rattle because I take so many pills to help my heart to get rid of the fluid and keep my cholesterol low. Next. So from my perspective as a patient, things that I think may be important are how much will Tic-Toc-PSI ease symptoms, tiredness, swelling, and shortness of breath? And will it reduce my risk of being in hospital? Next slide. So another question now. Pat, should the benefit of Tic-Toc-PSI in easing symptoms be assessed, A, in patients whilst they are taking Tic-Toc-PSI over up to a year prior to any changes to other therapies, B, in all patients 1 year after being prescribed Tic-Toc-PSI, irrespective of whether able to take the full course of or changes to other therapies, or C, after 1 year in the subset of patients who are able to tolerate Tic-Toc-PSI, irrespective of changes to other therapies. So, which do you think is a suitable answer here? So we'll just monitor the responses coming in, and similar to the previous questions, once we've got the majority of attendees providing an answer, we can take a look. So how are we doing with the responses coming in?
We've got about 68% currently. Okay. I'll just let it get another 5% through. Okay, and I'll end it there. And there we go.
Okay, so we're seeing 38% for A and 41% for B and 21% for C. So relatively evenly spread, I would say. No clear single preferred answer. So let's take a look at the next slide to see what we think. So actually, I think the responses were reflective in the fact that there is probably no clear single best answer here, but here's something that we could go with here. So for A, we could take a while on treatment approach, for B, a treatment policy approach, and for C, perhaps a principal stratum or treatment policy approach. Good, so let's go to the next slide now. So now moving on from a physician perspective. So as a physician, these would be some of the things that I would be thinking. So I'm a physician who treats patients with advanced heart failure. I often prescribe ACE inhibitors, beta blockers, diuretics, and possibly anticoagulants. If a patient worsens, I would consider adjusting their standard of care. For example, reviewing dose levels or combinations of above medications. The KCCQ measures symptoms, physical function, social function, and quality of life. And just as a reminder, the clinically significant improvement is an increase in total score of at least 20. Click again. So my question about Tic-Toc-PSI is, if I prescribe Tic-Toc-PSI, will the patient have an improved KCCQ of greater than or equal to 20 without requiring changes to other impactful therapies? And so now handing over to hear about the regulatory perspective from David.
Thank you. So just to make clear, this is even more definitely my personal view, as I'm no longer a regulator. So this is just what somebody might have said at some point. So I'm interested in ways of doing things that have minimal assumptions and don't overstate the benefit, because that would be an unfair representation of the benefit, which we would then trade off with the risk of using the medicine. And so one particular thing that I might be concerned with is when people can't tolerate treatment. And there's been discussion in the chat about this, and so that might lead, so obviously then that's treatment discontinuation. It might also lead to study discontinuation as well. In terms of, and so then we might have some data after treatment discontinuation, and in some patients we do not. But I'm not so interested in the thinking about what would have happened if they hadn't stopped taking the treatment. If you just build the slide, thank you. So I'm interested in how much better than Tic-Toc-PSI is in this trial on top of standard of care. Well, there might be other regulatory questions about whether it's just better than nothing, but that depends on the circumstance. But say that that's a reasonable thing to do. And so I might be thinking that if someone can't tolerate the drug, they might be considered a treatment failure. And also, if they die, that's a moot point about what to do with them, but maybe they could be considered a treatment failure too. So if we now have another question, please, on the next slide. So as a regulator, as I say, I don't want the benefit to be overstated. So which of these options might be overstating benefit? Well, we define a composite endpoint, a binary endpoint, where success is an improvement in KCCQ of a certain amount. But as well as that, we don't see anything bad happening. And we define what bad means. And then for all of those bad outcomes, we consider those as treatment failures. So that's A. B was the use of a hypothetical estimand, which is as though they don't discontinue the drug due to tolerability issues, or maybe both A and B are true, or maybe neither of these. So please vote now. How are we doing, Emily?
We are just over 65%. So I'll just let another couple through. And I'll close it there at 75%. And there we go.
Okay, so we've got a split on here, but so the favourite is B. And if we go to the next slide, that was the one I sort of gave a clue about that I wasn't overly keen on. I think A has potential, and so that would be the answer from a sort of my mythical regulatory perspective. But I'll hand over now for Antonia to think about the HTA perspective.
Thank you very much, David. So I am now going to play the role of a health technology assessor, representing, for example, a national health technology assessment agency such as the National Institute of Health and Care Excellence, NICE, in the UK, or EIWG, the Institute for Quality and Efficiency in Healthcare in Germany. HTA agencies, as we know, review, assess health technologies to then determine whether or not to reimburse them within the relevant healthcare system. HTA agencies tend to be interested in understanding how a new treatment compares to standard of care in clinical practice. And to understand, to perform this comparison, this assessment, HTA agencies look at the benefits of the new treatment, focusing on the clinical and in some instances, cost effectiveness consideration, and assessing, looking at a range of so-called patient-relevant outcomes, which should ideally reflect how patients feel, function, or survive. So given this premise, how can we translate the expectation of an health technology assessor in a relevant research question for our hypothetical treatment? Well, my question when I embark on the HTA of Tic-Toc-PSI would be, what is the added benefit of Tic-Toc-PSI versus standard of care in KCCQ scores, irrespective of changes to other therapies or discontinuation of treatment? Bearing in mind that, of course, standard of care varies in time and across geographies, and also reminding ourselves that HTA agencies will also want to look at other outcomes, other endpoints, not just uniquely KCCQ scores. So this is my question. Now let's test our knowledge, and let's just look into an hypothetical, how this translates into a quiz question. So as a health technology assessor, as we said, as we've seen, we are interested in estimating the treatment effects irrespective of changes to background therapy or discontinuation of treatment. When, as an assessor, I look at the protocol for Tic-Toc-PSI, what kind of strategy would I think would best reflect my expectations? Would it be hypothetical, principal stratum, a treatment policy strategy, composite variable, all while on treatment prior to changing background therapy? So over to you now. How are we doing, Emily?
We are just coming up for 70%. And still a couple coming through quite quickly, so I'll give it another couple of seconds. Okay, we'll go with 77%, and there are your results.
Thank you. Thank you. I can see that the vast majority of you have selected a treatment policy strategy. And indeed, this is the strategy that best reflects the question we were asking. I'd just like to add one important point here. We are essentially assuming that the experience of intercurrent event that patients go through within the context of a clinical trial can be generalized, can be thought of reflecting the experience that similar patients would go through when using the treatment in a real-world context. So it's very important for us to be mindful that the adoption of a treatment policy strategy, even if we do meet the expectation of, in this case, an health technology assessor, is not always straightforward. And we always need to look very carefully at what the protocol is telling us, what information can we gather around the intercurrent events that patients might have experienced. Thank you.
Thanks, Antonia. So I am playing the role of a statistician, which is easy for me because I am a statistician, but hopefully you might have similar thoughts if you're a statistician too, but we're hoping there's a variety of people from different areas on this call. So I see myself as someone who can perhaps help facilitate discussion. And my starting point is just trying to understand the clinical setting. I'm not a clinician, so I really need to work with the team and ask Nicole as the physician lots of questions so that I can really understand what happens when there is lack of efficacy or discontinuation in the treatment due to tolerability issue. What happens? Does somebody, would they instantly have other medications changed? And indeed, that is the situation here. So sometimes certain intercurrent events go hand in hand, and therefore it might be easiest, most straightforward and logical, if you like, to treat those together with the same strategy. But you don't have to treat all the intercurrent events all with the same strategy, but if you like, some of them will naturally go together. So when I'm trying to help define suitable estimands, I'm hoping that they're easy to understand and that they stand up to the scrutiny from the FDA and the EMA, and that we're not overstating the benefit, and that, you know, that we can actually estimate them without bias, or at least we're really clear what assumptions we're going to have to make so that we can test out those assumptions. And then lastly, you know, we want to be able to pick up a signal. So, you know, that's an important consideration too. So my question about Tic-Toc-PSI could be, well, what is the median difference in KCCQ when we take a worst value for treatment failures? So you'll see I've chosen the median here deliberately, because when we take a worst value for treatment failures, you know, well, which worst value do we choose? And we get into this debate about what we should take. And, you know, choosing, you know, a median as the summary is quite a nice way to handle this situation, so that the choice of that worst value isn't so impactful. Another question I have, I'm not sure if I'm really allowed two questions, but I've got two questions. What's the difference in proportions between Tic-Toc-PSI and the placebo of patients who will have a successful outcome? And that's defined as a clinically significant improvement of 20 or more, but without increase to other therapies or treatment discontinuation or death. So what we want to do next is just bring together the different viewpoints, and down the left hand side we've got the intercurrent events, and just a reminder of the symbols here. These blue symbols are all treatment discontinuation for different reasons, and the medication symbol here is talking about changes to medications that might impact, you know, be either for worsening symptoms or unrelated medical issue. So I'm going to pass over to Nicola, and we're going to work our way through the different roles in turn, thinking about what strategies we think might be appropriate for handling these different intercurrent events.
Thank you, Sue. So yeah, let's make a start with Pat, the patient. And as we saw in our quiz question, there may be differences of opinion between individuals. So I think Pat is probably most interested in understanding the benefit in those who can tolerate the treatment and not subject to logistical issues. So on the slide here, you see possible strategies that we could use illustrated with this yellow hand symbol for Pat. And then next, as a clinician, from the clinical perspective, I think it's important to assume a treatment failure for discontinuation of treatment for tolerability or loss of efficacy, or changes to therapies due to worsening disease. This, as we remember, is the so-called composite approach. And quality of life, to me, makes most sense in those whilst alive. So here you see these strategies illustrated with this black symbol. So now we can see what David thinks from a regulatory view.
Thank you. So, and if you can build the slide. So this is lots of purple there, not purple, sort of a pinky color for me. And I've got a special power of things that I don't like as well as things that I do like, because, and so just this to illustrate a point in the chat that came up about saying, well, regulators just want treatment policy. Well, so what's the problem? And that's not always true. And an example of that would be, imagine a patient whose symptoms worsen, and then they switch to another treatment that works very well. And then their KCCQ at 1 year is looking marvelous. That's not down to their original treatment. It's down to the treatment that they received afterwards. So I wouldn't be interested in that, attributing that success or treatment to, in that situation. So that's why there's a no entry sign there. Other things that I've mentioned already, of course, hypothetical strategies for patients who discontinue due to tolerability issues would also be a non-starter. So this composite effect offers a potential solution here where you can clearly define success and failure. I know there are downsides to it in terms of the power that the study might have as opposed to using KCCQ, but in terms of would a regulator accept such an approach, it does have that sort of straightforward attractiveness. Moving on to Antonia now.
Thank you, David. So what would an HTA agency prefer? So we know that potentially the default position by HTA agencies is really to look at a treatment policy strategy. Of course, in presence of an intercurrent event such as death, it would just not be feasible to collect relevant data and observation for our variable or endpoint after that intercurrent event. In that case, HTA agencies would be willing to consider a composite variable approach. I should like to add that we know by our experience that in presence of other types of variables or endpoints, particularly long-term outcomes such as overall survival, health technology assessment agencies that base their decisions on cost-effectiveness assessment, such as NICE, have tended to accept hypothetical strategies to correct for instances where patients might have experienced treatment switch in the relevant trial. But this picture, as it now looks, seems to be would be acceptable as far as the KCCQ total score is concerned. Now, let's see how Sue can help us navigate this complex set of options.
Okay, thank you. So when I was thinking where I'd put my thumbs up, this is what I went for. But yeah, you're right, it's quite complex and there's a lot of potential choices here. And interestingly, I've worked through this sort of process on almost pretty much the same clinical situation with a few different teams from different companies, and we ended up with different things, not surprisingly perhaps. But part of the point of Estimands, remember, is to be transparent and clear what we are doing. Now, treatment policy, first of all, my views there is I really do appreciate that HTA view about, it's interesting to, compare those treatment policies of Tic-Toc-PSI added to standard of care versus standard of care and follow through. Regardless of tolerability issues and changes in meds. However, does that really, when we're thinking about logistical issues like, needing to discontinue treatment just because of COVID lockdowns or unrelated medical issues requiring other treatments and that take priority, maybe the person's got a diagnosis of a brain tumor or something, something else there, is it then really relevant for us to be continuing to assess their quality of life thereafter? Is that really part of the treatment policy we want to compare? Is that the real world we're looking at? Maybe there's different real worlds out there. So I kind of, I just want to kind of think about that. And also, even if those things were to happen, you can't measure them. You can't carry on measuring the person, probably in these sorts of situations anyway, with the best will in the world. So then you're going to have an estimation issue arising. So I've kind of agreed with the clinical and regulatory view here that the composite might be a nice way to go. But I do also, I liked what Nikhil said from the clinical perspective about, this is a quality of life endpoint, and therefore while alive seems like a really sensible choice. And yeah, that sounded really good to me too. It might work better with measures that you can measure every day, like say from a wearable device or something like that. It might work better. But I then started to think, but wouldn't we want to show at least non-inferiority in terms of survival? And then I sort of did a calculation. I thought, what sample size would we need to do that to show that too? And it was thousands and thousands, tens of thousands. And I thought, maybe we should just bite the bullet and just use the composite strategy for death too. So that was sort of where my thinking led me. But ultimately, we need to kind of come together as a team, and we might want to pull out a few different questions of interest and try and somehow consolidate this. We're probably going to have to make some compromises. But remember, part of the point is to be really, really transparent. So we're going to go on to how can we formulate some estimands? And what we're going to do is we're going to think about a few different alternatives and try and write out some estimands. So the first estimand we're going to think about will be one that is primarily composite, but also taking a hypothetical strategy for these logistical unrelated medical issues. So we're calling that Estimand 1A. So also looking at this KCCQ total score at 1 year, we thought, yeah, let's keep the HTA folks happy. Ultimately, we do want our drug to be bought as well as approved and licensed. So we're going to add this treatment policy Estimand. And then just to give you a completely different kind of example, we thought we would jump to look at the endpoint of heart failure, hospitalizations, or cardiovascular deaths. And we're going to take a mostly treatment policy approach to that one too. So I just want to talk you through what these estimands might look like. And this is my particular templates that I have, but the order, sometimes it's better, the more natural that you take these in a different order. So bear that in mind too. But first of all, who is it we're wanting to study, we're wanting to recruit from, and therefore make our inference back to? It's patients with moderate to severe heart failure. What are the treatment conditions we're wanting to compare? Well, it was Tic-Toc-PSI versus placebo, both of those on top of standard of care for up to a year. But there's other things going on with treatments, isn't there? And in this case, we've decided to think about as though no treatment discontinuation due to logistical or unrelated medical issues, and no initiation of other therapies due to unrelated medical issues that might be impactful. Okay. And then, well, what is our population level summary? What is the difference in proportions of composite responders, where we're defining that composite responder on each individual as being an improvement of 20 or more in KCCQ at 1 year, with no lack of efficacy requiring changes to background therapies and no discontinuation of treatment for tolerability issues. And you can see I've put little 1s and 2s there to just sort of try and reiterate what these strategies are. So the 1 is there for the hypothetical strategy that we've used, and 2 for the composite strategy, where we've incorporated death, discontinuation due to tolerability or lack of efficacy as treatment failures. Okay, so let's then take a different approach now and define another Estimand, Estimand 1B, which was going to be using treatment policy except for death. So we've got the same target population, treatment conditions. You can see I'm using the pink text is being used to pull out those intercurrent events. Here, what's different to the last slide is that we're saying irrespective of treatment discontinuation and changes to background therapies for any reason. And then let's look at what is the difference in medians, and that's in the improvement in KCCQ total score after 1 year, taking the worst observed value from baseline to death for anyone who dies. Okay, and here we are using the treatment policy strategy and the composite strategy for death. So over to Antonia to introduce another Estimand for you.
Thank you very much, Sue. We've seen that HTA agencies are interested in a wide range of outcomes, and so are other stakeholders. So let's test our knowledge and build an Estimand around this different endpoint, cardiovascular hospitalizations. Again, we're focusing on the same target population, and let's continue. In terms of the relevant summary variable for the endpoint, in this case, we might want to focus on estimating the relative risk ratio in the rate of heart failure hospitalization, and we continue to build upon the ranges of endpoints here, introducing also or cardiovascular death during the first year, treated with Tic-Toc-PSI versus placebo on top of standard of care, irrespective of treatment discontinuation and changes to background therapy for any reason. This language continues to resonate. And what about the range of strategies that we might consider? Well, let's map these strategies to the relevant intercurrent events. We would continue to follow treatment policy strategy when it comes to assessing cardiovascular hospitalization. So we would estimate this endpoint irrespective of treatment discontinuation. We would consider a composite strategy for cardiovascular deaths. And finally, we might want to isolate the confounding effect that death from other causes might bring into our estimates. And in this case, we would consider adopting an hypothetical strategy for this specific intercurrent event.
Okay, thank you very much. So I'd just like to wrap up. I see we've only got 17 questions to answer, and we've only got 23 minutes left. So I'll be as quick as I can with the next section. So next slide, please. So this is just to summarize the importance of Estimands in protocols. And obviously to start with, just to say that you need to properly define the Estimand, using those 5 attributes in a meaningful way that's clear to all the relevant stakeholders, all of those people that we've been acting as today. We need to, and one of the other important advantages of the framework is it offers transparency. So you know what the question is and also how it's been handled in the analysis. Particularly for serious diseases, elderly populations, it's important to address death because it either will happen or could happen in the study, and so it's of relevance and needs to be addressed. The summary measure you choose needs to be clinically meaningful and also statistically appropriate, and we've heard views about that this afternoon. There have been some questions about, you might want to address a particular question that drives a particular Estimand, but can you actually estimate it? Some are easier to do that than others. And 2 particular examples where it can be more challenging are the principal stratum approach, or even the lovely treatment policy strategy that's so popular can be very difficult in the presence of missing data. So don't overlook that complication. And then finally, deal with the impact of the study assessments in the protocol. Next slide, please. So, as ever, you should think about these things early. And so this is when you're at the concept stage. This is when you need to use the framework first. After you've done that and made a decision on what you're going to do, you should then use the framework and the choice of Estimand to explain what you're doing to the relevant authorities. In this case, maybe regulators and HTAs. All of this should then make it clear what you need, what data you need to collect, what is crucial, particular for your primary. And so, for example, if you're adopting a treatment policy strategy, it's important to follow up patients after they've had their intercurrent events, because that will then reduce uncertainty that's caused by missing data. You also need to capture the reasons for various things happening. As you heard today, it's not just sufficient just to say they discontinued treatment. Why did they discontinue treatment? Depending on the reason, you might want to handle those patients or think about them in different ways in the analysis. Next slide, please. So we're back to our familiar first slide about this being a group exercise, and it's up to everyone around that table, and then with input from regulators and HTAs to define the question, to be clear about it. Some people might say, well, hold on, we've always had all these possibilities, so what's different? Well, the difference is this framework offers clarity about how to describe what you're doing to a lot of different people, and which I think is one of the great strengths of the approach. If you just go on to the last slide, we could put several hundred references down here, but we've just put a few. You've got a link to the training material for the addendum, which is very useful. There's a few papers there and some details of the Kansas City Cardiomyopathy Questionnaire, some design things, and also a paper by Antonio and others on thinking of things from the HTA point of view. But I think now we should probably move on to the Q&A session. Thank you.
Thank you, David. Well, thank you, David, and everyone else for a great presentation. So I will start with a question that started in the chat, a lively discussion after Nikhil presented the study withdrawal. Some people did not understand why study withdrawal will generate missing data. And there is still one anonymous attendee that is confused about events leading to missing data that are not intercurrent events. Anyone would like to answer that question?
So, well, I think some of the confusion might be that, yes, in some circumstances, people discontinue from the study, and by definition, say they're on experimental treatment, they will then not have access to that treatment after they leave the study. So they also then discontinue treatment. And so then an intercurrent event happens after they discontinue from the study. But discontinuing from the study by itself doesn't imply that you're an intercurrent event, because maybe you're not on active, for example, or maybe you're on a treatment that you can get outside of the study. So it depends on the circumstance. So I think it's just the fact that in the past, people were just thinking about study discontinuation defining the situation, and it doesn't do that by itself.
Yeah, thank you, David. The next question was posed by Sylvia. She's asking, how would you handle multiple intercurrent events occurring at different points in time? For example, a patient first uses rescue medication, subsequently discontinues treatment at a later point in time. Would you need to define priorities among intercurrent events? Anyone who would like to answer that one?
Sorry, I'll let someone else have a go next, but in terms of, so here it's the order that they happen. So if, for example, rescue medication happens first, and you define that you're not interested in what happens to people after rescue medication, then any subsequent intercurrent events doesn't matter, because you've already defined that you're not interested in that patient after they have the rescue medication. So in that circumstance, that would define things. But if you were adopting a treatment policy strategy, of course, then all of these intercurrent events are in some senses not as relevant because you're going to look at what happens to them regardless of them.
Thank you, David. Anyone else wants to add something else? Sue?
Yeah, well, I'll just add that, just reiterate the comments I made about sometimes with treatment discontinuation, it goes sort of hand in hand with other meds being changed, that these two things happen pretty much at the same time or in close succession in a lot of clinical settings. And if that's the case, you know, it might make sense to use the same strategy for each of them. And as David said, you know, it's the timing of the first thing happening that is the important one potentially. But yeah, you could end up with almost like a hierarchy of you know, needing to think about the ordering. And also on that sort of issue around timing, an interesting point is you know, if we start getting to hypothetical estimands, you know, at what point exactly do we actually select the data? You know, if you've got a treatment that's given like denosumab, that's given every 6 months, you know, discontinuing from that, what does that mean? Well, you know, that like you have your last dose. Well, the data is still really, really relevant for 6 months later after that last dose. So, and then there's other things, you know, in vaccine studies where we may be looking at PCRs, positives, you know, we're looking at immunogenicity, for example, and we're looking at, you know, things like a natural infection being an intercurrent event. And that's an interesting example too. Does that mean when we're trying to evaluate our antibody data and we're trying to sort of take out the impact of those natural infections, you know, what window do we take around that PCR positive, you know, and potentially we might want to go before that came to light. So, you know, it's that sort of, it's not as straightforward as it might seem, and you might need to give some thought to what we mean if we are going to take a hypothetical approach in terms of, you know, which data are relevant. I don't know if that helps, but
No, it helps. Thank you, Sue and David. I'll move on to another question that is related to patients. So this attendee said that he finds interesting that the patient's preferred strategy for handling different intercurrent events rarely seem to be aligned with the other parties like HTA, stats regulator, clinician viewpoints. Shouldn't the patient's preference have more relevance in the Estimand definition? Sorry, I think it's a very interesting question, and that's why I'm asking it. Anyone who would like to say something?
Well, yes, probably, but in terms of, there are some reasons why the Estimand that a patient might be unattainable in many circumstances. So we might always want to know what would happen if I could tolerate a medicine and this didn't happen and this didn't happen. And then to actually estimate that is very complicated. It doesn't mean that it's not the thing that we should be trying to estimate eventually, but if that gets to a situation that we can't really interpret it because the number of assumptions that are made, then we pragmatically have to do something different. And that's what happens in practice.
Thank you, David. Anyone else?
Nikhil, do you want to add to that?
No, I mean, I think that getting the patient's viewpoint is important, along with the other viewpoints. So I think just having that context and perspective is relevant. But I think I'm not sure I can sort of comment on that, whether it should take priority above all else, because I mean, I think each stakeholder's perspective is important from that perspective, and each stakeholder has a particular remit and role in the context of a therapy. So I think it's not so straightforward as saying automatically the patient's viewpoint must always be given greatest weight.
Okay, thank you, Nikhil. Let me see a bit. This is from an anonymous attendee. How can industry get FDA off the strong stance that treatment policy is the only estimate to use for regulatory and labeling decision making? Do you think that's possible? So I think, David, that's coming to you or anyone.
Well, it is possible and it's happened. So an example in nasal polyps, for example, where they don't use a treatment policy strategy for patients who have surgery after they start their treatment, because then your nasal polyps disappear because of the surgery, but obviously the people who receive the surgery are the ones who are getting worse over time and obviously not benefiting from treatment. So they use a composite strategy similar to the ones we alluded to today there. So that's another example where regulators, in the case the FDA, doesn't accept.
Not necessarily, will be always treatment policy.
So, but we can. There are more situations where I think a similar approach or a different Estimand that's looking at things slightly differently could be used, and we can just keep going with that in conversations with that.
So so the teams should be prepared to have a conversation with the regulators and try to convince them why the chosen strategy is valid.
Exactly.
Okay. I think this is more a stats question, so it goes for you. So ideal situation, was asked by Stephen K. So ideal situation for a phase 3 trial is in the SAP, the primary endpoint methodology is aimed at regulatory approval, likely to ITT population, to cover full population with perhaps statistical adjustment, if possible, for intercurrent events. And the other objectives, HTA, are catered for secondary analysis with predefined methods, so population, etc., dealing with ICEs. Thus, everything is pre-specified, but this is placing great burden on SAP, likely not doable. Maybe for Sue and Antonia.
So say that last bit of the question again.
I think that what the attendee is asking is, like, we select the primary Estimand in the SAP for the phase 3 trial, but then we know we have HTAs and other HTAs that are interested in different Estimands, and we are suggesting to specify everything in the SAP. Aren't we creating a lot of burden, and we might not be able to do all these analyses?
Well, I mean, most studies do, many analyses and produce hundreds of tables, in my experience. I think what we're trying to do is focus the questions and therefore align the methods and the sensitivity analyses that we want to do to those specific questions. So, and we're not predefining our Estimands in the SAP, we're predefining them in the protocol. This is not an issue for the SAP, this is an issue for the protocol, because sometimes the discussions we have make a difference to the way you set up the design of the study. It comes before the design, it comes before the CRF page. If we need to distinguish different reasons between for discontinuing treatment, we need that CRF page to capture that in a meaningful way. So yeah, these are issues for the protocol, and those key questions, should be in the protocol. Now, whether, I'd like Antonia's view on whether questions that are really targeting HTA, whether you feel the same way as I do, that, if there's an important question, we need to plan for that early.
Yes.
We don't want to leave it in the SAP. So
Absolutely.
What's your thoughts?
Yes, yeah. I completely agree, Sue. And it's really what David was alluding to at the beginning of our webinar. The Estimand framework provides a level of transparency in the ranges of discussions that as sponsor we embark on with different stakeholders at planning stage. So it's critical that we reach out to HTA agencies, gather their views, for example, through HTA early advice, and really understand what are the trade-offs that we might encounter. Are their expectations potentially unfeasible? would a clinical trial that is designed, for example, to ensure that we minimize any risk of bias that has strong internal validity, but to what extent would we be willing to sacrifice this for a trial that addresses more relevant questions for a broader ranges of stakeholders? It's this dialogue and this level of transparency that the Estimand framework really should empower us with. And if there are trade-offs, if there are challenging choices to make, then again, these choices will be made in a transparent way. So I'm really hopeful that going forward, HTA agencies will acknowledge the addendum more and more so going forward.
Thank you, Antonia. The next question, I see a couple of questions on the same topic, so I'm just going to take the one from Dimula. She asked, in the example you shared, it was a phase 3 study design using preliminary data from phase 2 study. Do we apply the Estimand framework in phase 1 and phase 2 studies?
So we can just start by saying that the addendum didn't specify where it should be used. It can be used in general for all studies, and I would advocate that it can be. So when it says do we apply, we can apply the Estimand framework in phase 1 and phase 2, and I would suggest that the value of the framework is there, and so I would like to see it used. Is it used? Obviously, and historically it hasn't been, and the earlier you go in development, the less likely you are to see Estimands routinely used at the moment. But it's something I think many of us on this call would like to see happen, and we are considering how to do that at the moment.
Thank you. So with that, I mean, Sue, would you like to add anything with regards to the application of the Estimand framework in phase 1 studies?
Yeah, for sure. No, I agree with David. So basically, the ideas can be applied. But I guess one of the more interesting things is which perhaps we haven't gone into a huge amount of detail today, but when you look at the training slides from ICH, they have 4 steps between, trial objective and Estimand. There are 4 steps of a thinking process that they outline. And it's very much, really understanding that clinical setting, the intent of the treatment, and then identifying your intercurrent events, and actually just doing that. If you do nothing else, just doing that in a phase 1 and phase 2 study can be very, very helpful. And just spending the time, I've just got a study just this week where just the first 2 steps, we've had more than 2 hours of discussions in the team. We haven't quite got to the Estimand yet. We're literally just trying to understand the setting and all those intercurrent events. This particular example I'm thinking about is in kidney dialysis kind of situation. It's quite complex, but yeah, it's I just really think it's a very, very helpful once you get into this mode of thinking and you get that dialogue going between your team and you get around the table and really pull apart those objectives. I don't know, it's just fascinating for everybody, and you can work so much better as a team. So if all this does is make us work better as a team, I think it's a brilliant thing. So I just hope I inject some enthusiasm to have a go at applying this. And once you start getting into that mindset, you can't switch it off. If somebody asks me a question, could be a study, there's not an Estimand in sight, I almost can't help thinking about this process now. I find it so helpful. So there you go.
Thank you, Sue. Definitely, you were very enthusiastic. I think, no, we don't have time for another question. So I think in the interest of time, I would like to wrap up the webinar here, but I would like to thank all the panelists for an amazing presentation and a lively discussion. And also I would like to thank the audience for attending, taking time of your day to hear this webinar and for raising interesting questions. As it has mentioned before, the recording is going to be available in the PSI website as open access, and we will also upload it in the YouTube channel of FPI. So with that, I'm closing the webinar. Thank you to everybody.
Thank you. Bye-bye.
Thanks.